Introduction. Welcome, esteemed medical students, to today's lecture on hypoxic brain injury and its various aspects. In this comprehensive session, we will explore the intricate anatomy and physiology of the brain, delve into the cellular mechanisms of oxygen deprivation, discuss the implications of hypoxic ischemic encephalopathy in newborns, and understand the molecular pathways and signaling cascades involved in hypoxic brain injury. Furthermore, we will study the role of neuroprotective interventions, advanced neuroimaging techniques, and biomarkers for early detection, prognostication, and monitoring of hypoxic brain injury. We will also explore the benefits of hyperbaric oxygen therapy, the impact of cardiac arrest on hypoxic brain injury, post-resuscitation care, neurocognitive sequelae, and functional outcomes in survivors. Lastly, we will tackle the ethical considerations and communication challenges associated with withdrawing life-sustaining treatment for patients with severe hypoxic encephalopathy. So, without further ado, let us delve into the intricate world of hypoxic brain injury. To truly comprehend the ramifications of hypoxic brain injury, we must first understand the complex anatomy and physiology of the brain. The human brain, a masterpiece of evolution, consists of multiple interconnected regions, each responsible for specific functions. The cerebrum, with its 4 lobes, the frontal, parietal, temporal, and occipital lobes, governs higher cognitive functions, motor control, sensory perception, and visual processing, respectively. The cerebellum coordinates voluntary movements and balance, while the brainstem regulates vital functions such as breathing, heart rate, and consciousness. The brain's intricate architecture includes billions of highly specialized cells called neurons. These neurons communicate through electrochemical signals via synapses, forming large and interconnected neural networks. This intricate web enables the brain to receive, process, and respond to a multitude of stimuli, facilitating our perception, thoughts, emotions, and actions. Oxygen is of paramount importance for maintaining neuronal homeostasis. Deprivation of oxygen, known as hypoxia, disrupts the delicate balance of neuronal function and ultimately leads to cell death. Within minutes of oxygen deprivation, ATP production diminishes, leading to a cascade of events leading to cell dysfunction and death. These events include the accumulation of reactive oxygen species, ROS, mitochondrial dysfunction, excitotoxicity, and impaired regulation of cytoplasmic calcium. The intricate mechanisms underlying neuronal cell death during hypoxia involve apoptosis, necrosis, autophagy, and other distinct pathways. Understanding these cellular processes is crucial in devising therapeutic strategies to combat hypoxic brain injury effectively. Hypoxic ischemic encephalopathy, HIE, poses a significant challenge in neonatal medicine. This condition occurs when newborns experience oxygen and blood flow deprivation to the brain, often during or around the time of birth. HIE can lead to severe long-term neurological deficits and, in the worst cases, can be fatal. The etiology of HIE is multifactorial, involving prenatal, intrapartum, and postnatal factors. Understanding the pathological processes underlying HIE can guide early diagnosis, prognostication, and implementation of appropriate therapeutic interventions to improve outcomes and minimize long-term disabilities. Hypoxic brain injury triggers a complex interplay of cellular signaling pathways, impacting the balance between cell survival and death. Understanding these molecular pathways is fundamental to identify targets for neuroprotective strategies. Various signaling pathways, such as those involving hypoxia-inducible factors, HIFs, ACT, MOPC, and NF-κB, play pivotal roles in determining cell fate during hypoxic stress. Targeting these pathways may offer promising avenues for future therapeutic interventions aimed at minimizing neuronal damage in hypoxic encephalopathy. In the search for effective treatments for hypoxic brain injury, researchers and clinicians have explored numerous neuroprotective strategies. These interventions aim to attenuate the cascade of molecular and cellular events triggered by oxygen deprivation and, consequently, reduce neuronal injury. Pharmacological agents, such as NMDA receptor antagonists, antioxidants, and free radical scavengers, have shown promise in preclinical studies. Moreover, therapeutic hypothermia, a well-established intervention, has demonstrated efficacy in reducing mortality and improving neurological outcomes in neonates with hypoxic ischemic encephalopathy. Continued research is crucial to explore novel approaches and optimize the use of existing neuroprotective interventions. Advancements in neuroimaging technologies have revolutionized our ability to evaluate and understand hypoxic brain injury. Traditional techniques, such as cranial ultrasound and conventional magnetic resonance imaging, MRI, have their limitations. However, newer modalities, including diffusion-weighted imaging, DWI, perfusion-weighted imaging, PWI, functional MRI, fMRI, and magnetic resonance spectroscopy, MRIs, offer a more comprehensive evaluation of the cerebral damage. These advanced neuroimaging techniques provide invaluable insights into the extent of injury, help prognosticate outcomes, guide therapeutic interventions, and monitor the response to treatment. Accurate and timely detection of hypoxic brain injury is imperative for initiating appropriate management strategies promptly. Biomarkers play a crucial role in identifying patients at risk, providing prognostic information, and monitoring the response to therapeutic interventions. Biomarkers encompass a broad range of molecular, biochemical, and imaging-based markers, including serum markers, neuroimaging markers, and electrophysiological indicators. The discovery and validation of specific and sensitive biomarkers hold immense potential in improving the accuracy and efficiency of diagnosing, prognosticating, and monitoring hypoxic brain injury. Hyperbaric oxygen therapy, HBOT, involves delivering oxygen at increased atmospheric pressure to enhance tissue oxygenation. HBOT has been widely used in various clinical settings, including hypoxic brain injury. By improving tissue oxygenation, HBOT aims to mitigate the cellular and molecular damage caused by hypoxia and restore function. While the evidence supporting HBOT in hypoxic brain injury is still evolving, early research and anecdotal case reports demonstrate its potential as an adjunctive therapy. Further randomized controlled trials are necessary to elucidate HBOT's optimal dosage, timing, and long-term outcomes in hypoxic encephalopathy. Cardiac arrest-induced hypoxic brain injury poses unique challenges due to the sudden and profound interruption of oxygen and blood supply to the brain. The duration and severity of hypoxia experienced during the cardiac arrest significantly influence the extent of brain injury. Rapid initiation of cardiopulmonary resuscitation, CPR, and advanced life support measures are crucial to restore circulation and prevent further neuronal damage. Post-resuscitation care, including targeted temperature management and neuroprotective interventions, plays a pivotal role in minimizing neurological sequelae in survivors of cardiac arrest. The management of patients with hypoxic brain injury extends beyond the initial resuscitation phase. Post-resuscitation care encompasses a multidisciplinary approach aimed at minimizing secondary brain injury, optimizing systemic and cerebral perfusion, and promoting neurological recovery. Strategies such as targeted temperature management, blood pressure optimization, glucose control, seizure prophylaxis, and maintaining adequate oxygenation are paramount. Continued advancements in post-resuscitation care protocols are vital to improve survival and reduce long-term disabilities in patients with hypoxic encephalopathy. Survivors of hypoxic brain injury often face significant neurocognitive impairments and functional limitations. Memory deficits, attentional difficulties, executive dysfunction, and emotional disturbances are commonly observed sequelae. Additionally, survivors may experience motor deficits, speech impairment, and impaired social interactions, significantly impacting their quality of life. Comprehensive rehabilitation programs that address physical, cognitive, and psychosocial aspects are vital in promoting optimal functional outcomes and facilitating reintegration into society. When faced with severe hypoxic encephalopathy and poor prognosis, the ethical dimension of decision-making becomes paramount. Medical professionals must engage in candid discussions with patients' families, respecting their autonomy and ensuring the best interest of the patient is upheld. Withdrawal of life-sustaining treatment, including mechanical ventilation and artificially administered nutrition, raises unique ethical considerations and communication challenges. Sensitivity, empathy, and shared decision-making are essential to navigate these complex situations, ensuring compassionate end-of-life care for patients with severe hypoxic encephalopathy. In conclusion, hypoxic brain injury represents a complex and multifaceted condition with far-reaching implications. Understanding the intricate anatomy and physiology of the brain, cellular mechanisms of oxygen deprivation, and the clinical manifestations of hypoxic ischemic encephalopathy is fundamental for healthcare professionals. Additionally, exploring molecular pathways, neuroprotective interventions, advanced neuroimaging techniques, and biomarkers enhances our ability to diagnose, prognosticate, and treat this devastating condition effectively. Lastly, addressing considerations and challenges associated with withdrawal of life-sustaining treatment ensures compassionate care for patients and their families. By expanding our knowledge and implementing evidence-based interventions, we can strive towards better outcomes and improved quality of life for individuals affected by hypoxic brain injury.